All right, today we're going on a bit of a journey. We're heading into a space that's absolutely critical to your oral health, but it's almost completely invisible. We're talking about the periodontal pocket. We're going to explore this hidden world right below your gum line to really understand how it forms, what it's made of, and what it tells us about the health of our teeth and gum. So, what's actually hiding in that tiny little space where your tooth meets your gum? It's not just empty space, It's a dynamic, microscopic environment. And getting a handle on what's going on there is the absolute key to understanding gum disease.
Now, in a perfectly healthy mouth, this little space is called the gingival sulcus. I want you to think of it like a tiny, shallow moat right around your tooth. The magic number here is 1 to 3 millimeters deep. That's our healthy baseline, a clear sign of happy, well-attached gums. This is our starting point for everything we're about to cover.
But what happens when things start to go wrong? This is where that healthy, shallow sulcus begins to transform into something completely different. Let's watch how this space can evolve from a state of health to a state of disease. So when that shallow sulcus deepens because of disease, we stop calling it a sulcus and start calling it a periodontal pocket. And this isn't just a matter of it getting a little deeper. It's a fundamental shift. It's one of the most important clinical signs that periodontal disease has really taken hold.
So, how does this actually happen? How does it get deeper? Well, there are two main ways this can go down. On one hand, your gum tissue can just get inflamed and swell up, moving up the crown of the tooth. We call that coronal migration. But on the other hand, and this is the more serious one, the actual attachment of the gum to your tooth can start to move down the root, destroying tissue as it goes. That's called apical migration.
And this animation shows that difference perfectly. Over on the left, you can see the gums are just puffy and swollen, moving upwards, which makes the pocket seem deeper. But on the right, that's the real problem. You see the attachment itself moving down the root, and that means the underlying support structures are being destroyed. And what's really tricky is that often both of these things can be happening at the very same time. Okay, so this whole distinction between simple swelling versus actual tissue destruction, it leads us to a really crucial classification system that every clinician uses to figure out what's going on. So this all hinges on a critical landmark on your tooth, the CEJ, or cemento enamel junction. Think of it as the tooth's natural waistline, where the shiny crown meets the root. A false pocket, or a pseudo-pocket, is just from swelling. The bottom of that pocket is still right at the CEJ. But a true periodontal pocket, that involves irreversible loss of attachment, where the bottom of the pocket has moved down the root past the CEJ. And that, right there, is the critical difference. And when we talk about these true pockets and attachment loss, what we're really getting at is the destruction of the very bone that holds your tooth in its socket. This is where things get serious. Now, the pattern of this bone loss gives us another way to classify pockets. Take a look at the image on the left. That's a super bony pocket. Here, the base of the pocket is above the crest of the bone, and you can see the bone loss is kind of flat or horizontal. Now, look at the right. That's an infrabony pocket. The base of the pocket is actually below the bone crest, creating this deep, vertical, almost trench-like defect in the bone. This table really breaks down those key differences. The big things to notice are where the pocket base is relative to the bone, the pattern of the bone loss. Is it horizontal or vertical? And even the direction of these tiny little connective tissue fibers. You can see how in infrabony pockets, everything gets reoriented. These are often way more complex to treat because of that deep, contained bone defect. Pockets aren't just about depth. They're actually three-dimensional problems that can wrap around a tooth in some pretty complex ways. So the most basic type is what we call a simple pocket. It's exactly what it sounds like. The pocket, the defect, it's just on one single side of the tooth. Okay, next up we have a compound pocket. Now, this is like a continuous channel. It starts on one surface and wraps around a corner of the tooth to involve a second surface, or even more. And finally, we have the most intricate of all, the complex or spiral pocket. This thing starts on one surface and literally spirals its way around the tooth to another surface that isn't even next to it. These are super tricky because the opening you see on the gums might not be anywhere near the deepest part of the pocket. You see these a lot in furcation areas, right where the roots of a molar split. So, with all this anatomical complexity going on, how in the world do clinicians actually assess the situation in a patient's mouth? Well, it all comes down to a really simple measurement. Using a tiny ruler, it's called a periodontal probe. Your dentist or hygienist measures the depth of that sulcus or pocket. And these numbers tell a huge story. 1 to 3 millimeters, you're in the healthy zone. Once you hit 4 or 5 millimeters, that's a sign of mild periodontitis. As those numbers climb up to 7 millimeters and beyond, we are now in the territory of advanced disease, and the risk of losing that tooth becomes very, very real. But hold on, that depth measurement is only one part of the story. The actual character of the soft tissue, the wall of the pocket itself, tells us a ton about whether the disease is actively raging or if it's in a more quiet, dormant state. The difference is all about what the tissue looks and feels like. An active edematous pocket wall is going to look reddish blue, it'll be soft and spongy, and it bleeds at the slightest touch. That's a huge sign of ongoing inflammation and destruction. In contrast, an inactive fibrotic pocket wall can actually look deceptively healthy. It's firmer, it's pinker, but here's the catch. Even though the active inflammation has calmed down, the deep pocket and all that underlying bone loss are still there. So we've journeyed all the way from a healthy little sulcus to the very complex world of the periodontal pocket. We've seen how it forms, the different ways it's classified, and how it's measured. You now have the knowledge to understand what's happening just below your gum line. So the only question left is, do you know what your numbers are? Having that conversation with your dentist might just be the most important step you can take for your health. If you've ever sat in a dental chair, you probably know that moment. The hygienist gently slides a small metal probe between your teeth and gums and starts calling out a series of numbers. It seems pretty simple, right? But that one measurement is actually a gateway to a hidden world. Today, we're going to take a journey from that familiar dental chair all the way down into the microscopic battlefield of what's called the periodontal pocket. Okay, so let's start with what we all know. This is a periodontal probe, and yeah, it's measuring the depth of that little V-shaped space between your tooth and your gum. But those numbers, they are so much more than just a measurement. Think of them as a clinical shorthand for the health of the entire foundation that's holding your tooth in your jaw. So what is this tool really measuring? I mean, is it just an empty space? Or is it a clue to something much, much deeper, a quiet but really destructive process that's happening just out of sight? Well, let's find out. All right, here's our game plan for this explainer. We're going to start by defining the problem. Then we'll zoom way in to see the anatomy of the damage. We'll witness the actual cellular battle that creates it. And then we'll inspect the aftermath. And finally, we'll zoom back out to see how clinicians read these signs and what we can actually do to restore health. First up, let's get on the same page. What is it that turns a normal, healthy gum sulcus into a serious problem? So here's the absolute key. A periodontal pocket isn't just a deep space, it's a diseased deepening. This happens when the very tissues holding your tooth in place, the bone and the ligaments, are destroyed. That destruction causes the biological seal around the tooth, called the junctional epithelium, to basically peel away and start creeping down the root. And this slide illustrates that difference perfectly. Have a look at the image on the left. That's what we call a pseudo-pocket. See how the gum is just puffy and swollen? That swelling makes the space seem deeper. But look, the underlying bone is totally fine. Now look over to the right. That is a true periodontal pocket. You can literally see the loss of supporting bone. That's a sign of active disease, not just some temporary inflammation. Okay, so when that bone is lost, it doesn't just vanish into thin air. It actually erodes in very specific patterns. Understanding the anatomy of that destruction, well, that's the next critical piece of the puzzle. You know, clinicians have a really clever way of classifying these bone defects. It's all based on a simple but powerful idea: how many bony walls are still standing around the root of the tooth. And this isn't just academic. This classification is absolutely critical because it tells them the best way to treat it and what the chances are for regenerating the lost bone. So a three-wall defect, sometimes called an intrabony defect, is kind of like a box with three sides still standing. That one has the best shot at healing. A two-wall defect is actually the most common, and it often forms a crater between the teeth. Then you have a one-wall defect, which is much trickier to treat. And sometimes you get a weird mix where the shape of the defect actually changes as you go deeper. But how do we get from healthy bone to these really destructive holes? Well, for that, we need to zoom in, way in, down to the cellular level and witness the battle that kicks this whole thing off. Okay, this is so cool. Think of this diagram as a map of the war zone. Up at the top, you've got the invaders, calculus and bacterial plaque. And then as you move down, you can see the progressive breakdown of the body's defenses, zone by zone, from the seal around the tooth down into the deep connective tissue fibers. So it all starts with bacteria. Our own immune cells, especially these frontline soldiers, called neutrophils, or PMNs, they rush to the scene. But in the process, they, along with other cells, release these enzymes called MMPs. Now, these MMPs are supposed to help remodel tissue, but here they go haywire, just dissolving the collagen that gives our gums their structure. And in this really strange twist, the very cells that are supposed to build collagen, the fibroblasts, actually start eating the existing fibers too. All this damage signals the epithelium to grow and send these little fingers down into the weakened tissue below. And here it is. This is the tipping point. As more and more of those neutrophils flood the area, they eventually make up over 60% of the cells in that epithelial seal. And at that point, the tissue just can't hold itself together anymore. It loses its cohesion, it starts to fall apart, and it detaches from the tooth. So let's just put that all together. It's a cascade. First, the supporting collagen gets destroyed. Then, the epithelium tries to patch the damage, but it ends up just growing downward. And finally, that leads to detachment from the tooth, and boom, you've got a pocket. Okay, so the pocket's been formed, but what does it actually look like on the inside? Let's take a look at the aftermath of this whole cellular battle. So every pocket has two walls. The soft tissue wall is swollen, or edematous, and it's just packed with inflammatory cells. The other wall, which is the root of the tooth, is now exposed. The tiny ligaments that once anchored it to the bone, called Sharpie's fibers, start to break down. This lets bacteria invade the root itself, creating these dead or necrotic patches on its surface. And you can see that invasion right here. This is a real slide. Look at all that dense, dark purple staining. Those are all the inflammatory cells that have just swarmed into the tissue, keeping that cycle of destruction going from the inside out.
So the pocket itself becomes this reservoir of junk. It's filled with more bacteria, shed skin cells, inflammatory fluid, white blood cells, and often pus, which is basically just a soup of dead and dying white blood cells that lost the fight.
All right, we've seen the absolute chaos at the microscopic level. Now let's zoom all the way back out to the dental chair and connect this cellular drama to the signs a dentist or hygienist can actually see and feel. This is where it all clicks into place. You know that bluish-red, shiny look the gums can get? That's caused by stagnant circulation and all that swelling in the tissue. Why does it bleed at the slightest touch of a probe? Because that probe is touching the ulcerated, raw inner wall of the pocket that we just saw. And if pus comes out when you press on it, that's a direct sign of all that active, gooey inflammation happening inside. Now, let's go back to those numbers. The probing depth just measures from the top of the gum line, but remember that pseudopocket? Swelling can totally throw that number off. The real gold standard is something called the clinical attachment level, or CAL. This measures from a fixed landmark on the tooth, basically where the crown meets the root, down to the bottom of the pocket. CAL tells us exactly how much of that precious support structure has truly been lost for good. So, understanding the disease is one thing, but how do we fight back? Let's wrap up by looking at the strategies for getting rid of these pockets and actually restoring health. The approach really has a few different phases. Goal number one, and the most important, is to get rid of the bacteria with a deep cleaning. For pockets that are too deep to clean, surgery might be needed to reduce their depth. And for those specific bony defects we talked about, especially those nice three-walled ones, we can actually use regenerative procedures with bone grafts to rebuild what was lost. Wow. So we've gone from a simple measurement in the chair down to a complex war between cells and all the way back. Seeing how our own body's response is part of the problem, it really changes your perspective. And it leaves us with one final thought. Now that we've seen this battle up close, how can we better support our body's own defenses to stop this fight before it even begins?